But anyway, I'm Jerry Bloom. I'm based at the Institute of Development Studies in the UK and also working with my co-facilitator, Priya Balasubramanian, in organizing what we call a platform for research and mutual learning on the management of mixed health systems. And the good news for us is we have a session really looking at what is probably at least half of the health sector, the private sector, and the challenge of engaging. I guess the bad news is that we have a special section on engaging with the private sector when this is an awful lot of what happens in global health. But on that note, we're calling it private sector and commercial determinants, but particularly looking at the challenges and opportunities of engaging with the private sector for improved health outcomes and improved health services. So I hope, and we will encourage you, we have a great panel with a lot of different experiences, but I'm sure we have an audience with a lot of experience as well. And we'll of course encourage you to make comments or ask questions. But I'll now pass on to Priya.
Thanks, Jerry. And so those of you sitting at the back, don't feel shy. We do feel rather elevated in this platform. So we don't want to look like we're speaking down, but more having a lot of energies coming from you, the audience. So thanks again for joining us this morning. My name is Priya Balasubramanian. I am affiliated with the Center for Sustainable Health Innovation Space out of Singapore, and I'm cross-affiliated with the Public Health Foundation in India, and a close collaborator with Jerry on mixed health systems or pluralistic health systems, as we researchers like to call it. I'll just set the stage for this session a little bit with a couple of slides so that you understand context, and then we'll move on to hearing this really lovely panel here. So today's session is really around the role of the private sector and commercial determinants of health, and establishing mechanisms of engagement in dealing with this very vibrant sector. A lot of the emerging economies are mixed health systems where you have a very robust participation of the private sector along with public sector or state-driven services. So just trying to move this. Okay. So actually our journey kind of began between 2018 and 2022, where Jerry and I began to have a series of consultations to kind of deep dive into public-private engagement and the kind of new models that were happening. There was technology that was disrupting a lot of health systems in care provision, access, and financing. There were also a lot of innovations happening in many countries that were changing the way people were looking at health and how health systems were invariably going to be managed. And so we had a series of consultations that began in India, moved on to Rwanda, Hanoi, Colombia, in Latin America, as well as in Argentina. And basically the consultations explored a couple of things. We looked at issues and actions identified by participants as critical to the management of innovations and digital transformations in health systems. We looked at generating fresh ideas on how private sector can engage with research and researchers to partner more effectively with governments, as well as public health mechanisms across populations and levels of care. And we also looked at sharing shared value creation and alignment, both through evidence as well as opportunity between non-state actors, as well as the government, to jointly identify health priorities for interventions, engagement to strengthen country health systems. Next slide. Okay. So the main purpose of this session is really I think there's something missing, or there's one. Yeah. So when we were looking, when we had this diverse interaction with multiple stakeholders, a couple of things really emerged, which may not be new to you, but really that in the end, there's really no one best practice model for countries to replicate. because digital and health system innovations have already, disrupted existing arrangements. COVID-19 kind of reduced the barriers to resistance to digital transformation as well as innovation, especially over the last couple of years. And that has really changed the way people as well as entrepreneurs have been thinking about engaging with health systems at large. And therefore, it's important to test new approaches, document what works and what doesn't work well, and why that's happening. So a couple of learnings that came out of these consultations were that non-state actors, or rather the private sector, both for-profit and not-for-profit, have really complemented public sector response to COVID-19 in many aspects of country health systems: supply chain, service delivery, products, diagnostic services. But governance arrangements need to adapt to local contexts if we're going to learn how to manage this new diaspora of actors. Stakeholders with different perspectives need to build on a common understanding on the structure of the health system and challenges to be addressed. And it's very important to take a learn by doing approach by identifying potential problems as well as testing strategies for addressing them. There is also a need for early warning for unintended consequences when you're engaging the private sector to enable adaptation of these governance arrangements. And interventions need to be national, regional, as well as global to be able to make an impact. So the mechanisms needed to support local learning and mutual learning between countries becomes all the more critical when we are looking at this context of rapid change that is happening. So can we have the previous slide? So this particular session is really to interrogate what these rules of engagement are across sectors for health system governance in relation to equity, access, and provision towards achieving global health goals. The purpose of this session is to identify more productive strategies for private sector engagement, has decades of working with the private sector, especially in relation to governance and anti-corruption. We also have to the extreme right, Mr. Rubaiyat Khan. He's the founder and chairperson of the Jion Foundation in Bangladesh. He's a techpreneur, an entrepreneur in residence, and the director of health programs of the Endless Network. Welcome, Rubaiyat. And last but definitely not the least, we have Dr. Christian Herrera. He is the senior health specialist, Latin America and the Caribbean region of the World Bank's Health, Nutrition, and Population Practice. He also has a former hat where he was a senior officer in the Ministry of Health of Chile and held the position of Vice Minister of Public Health in the Chilean Ministry of Health. And so he brings with him a state or a government angle as well. So without much ado, let's get started, and I'll turn over the floor to Jerry. So we can maybe begin with the first round. So we can invite Monica to kind of.
You want to sit here or do you want to?
I'm going to go there because I have some slides. Thank you very much, Priya, and thank you to Jerry and the organizers for inviting me to join you for the panel today. So I'm going to start with a few slides and introduce a little bit the work that we have been doing. I'm just going to wait for my slides to come up and keep talking. But before I do, and forgive me for the audience who are here online, can I just have a show of hands? How many people had heard of commercial determinants of health before seeing the session? Okay, that's not bad. We have about half of the room. Thank you for being honest, those of you that are not. So in that case, I feel vindicated. I'm going to give you a little bit of a whistle-stop tour as to what they are and why they matter. And then in the discussion, I hope we can talk about what we can do. So commercial determinants is a relatively new phrase. It's also sometimes called the commercial dimensions of social determinants of health. And the use of the term really has emerged over the last decade. It's been largely driven by work in the non-communicable disease space. Of course, tobacco is our poster child for work on tackling the harms from commercial determinants, but also increasing work in alcohol and food. But the roots of commercial determinants are far, far deeper. We can go back to Alma Ata, the origins, and the Ottawa Charter, which calls on the health sector to think about those outside of our own room and how do we work with other sectors, how do we work with other partners. And there have been many examples of how this has been done very productively, and Priya mentioned it. So we've had these two dichotomies that have been pulling. So increasingly the rising attributable harm, the burden of non-communicable disease, the unjust burden that places on our populations, but also the growing understanding and that the private sector has a key role to play, particularly in health and development. So this has brought the concept together, and commercial determinants as a term used by the WHO encompasses both of these. So it's a very neutral term. And the definition of that, and there's a definition in your program, but the WHO definition is that the commercial determinants of health are those conditions, actions, and omissions that affect health. So this is a very broad definition that these arise in the provision of goods or services for payment and include commercial activities as well of the environment in which commerce takes place. So we're talking about an ecosystem of commercial actions, an ecosystem of commercial actors, and that these can be beneficial or detrimental for health. And the challenge for us as a health community is to really understand how they impact the benefits and the harms, and how do we lever that. More recently, there have been two definitions published that I wanted to share with you because they're a little bit simpler. So this is a 2018 definition. The first being the commercial determinants being the activities of the private sector that affect the health of populations. And I think that's the one that we've used here. But interestingly, just last month in the Lancet series on commercial determinants, the authors proposed that this is also the systems and practices and pathways through which commercial actors drive health and health equity. So this is a very important framing, and it moves us from commercial practices all the way through into the economic determinants and the economic structures and drivers of health equity at a broader level. And I'll talk about that a little bit more. And it's very important, and I mentioned this at the beginning, that commercial determinants is framed from an academic perspective, from a public health perspective, as a social determinant of health. And here this is the framework that was presented in the Lancet series, and I do apologize, I speak very quickly as a native English speaker, I will try and slow down. And as you can see, and not to go through this in detail, but I would encourage you to read the description in the article that was published by Anna Gilmore and colleagues. The commercial drivers and forces impact on all aspects of the social determinants framework, if you like, the Whitehead and Dahlgren diagram, from the health system, which is of course a very key social determinant in this concept, all the way up to our power structures and our political systems. So as WHO, we developed a way to try and conceptualize this in a more simple way through the intervention framework on commercial determinants. And this gives us two impact domains. Very simply speaking, the commercial impacts on physical and social environments, cultures and behavior. So the determinants impacts. And secondly, the commercial impacts on regulatory systems and processes, whether we're talking at local level, national level, or global levels. And two sets of drivers of these impacts. The first being improving the corporate business operations, so core business from supply chains, employment, labor market conditions, through market presence, marketing, and so on. And then the second through corporate citizenship and personhood. So the institution that is the commercial actor, how the commercial actor interacts with the political system, with the public, the broader public through CSR and other activities. This allows us to delineate a little bit of what we're talking about and moves us out from some of the discussions that are very prominent in the literature around marketing of unhealthy products, for example, and into a more holistic social determinants conceptualization of commercial determinants. And you've heard me use the term commercial actors, and this is very important because the plurality, and this is not new for anyone in this room, of course, that we're talking about a very diverse ecosystem of actors. And Priya, you mentioned it, from third sector actors, from public sector actors. And the key in the definition of commercial determinants is that we're talking about those that partake in commercial activities. So it is not the nature of the actor themselves, but rather their practices and what they do. So I'm going to stop now. I think my last slide, if I can get to it. It's a little bit frozen. It's my conclusion slide, so I need to. Oh no, second to last slide. So one, and I don't have time today to go through the different activities that we're undertaking, but I want to mention the global report on commercial determinants. So this is the focus of the work of us in headquarters. So we're working towards synthesizing the evidence and presenting recommendations for action, which we hope to publish next year. But there's a number of different activities that are also underway at the regional level and also the country level within WHO. And then finally, I'm going to leave us with the task or the ask from the UN rapporteur on the special rapporteur on the right to health. And in her report last year to the UN General Assembly, she challenged us because in tasking us to not forget that commercial determinants have deep roots in colonialism, slavery, and asymmetries of power, and the extractive and exploitative nature that unfortunately are part of some of these relationships are very important for us to remember when we think about this in terms of health equity impacts. And I'm going to stop there, and thank you very much.
Perfect. Thanks, Monica. Can I invite Rubaiyat to maybe give us his perspective from the technology point of view?
Thanks, everyone. Thank you, Priya and Jerry, for inviting me to this auspicious panel. Really honored to be part of this esteemed group of colleagues. I hope that the 14 years that I've spent, although I recently joined a family foundation, the 14 years that I've spent working in the private sector with global development goals would allow me to speak with some honesty and granularity on some of these issues. So I started my journey. I just wanted to start off talking about a bit of my journey, and I'll try to elaborate on some of my experiences as I go through it. So I started my journey about 17 years ago, helping my father work with global development organizations like the World Bank and WHO, where he was consulting as a researcher. And one of the things that I noticed very early was how much in the analog era the world of development was at that time. A lot of the, everything was happening on paper, reporting used to take 5 to 10 days at the end of the month. So there was a lot of things that, coming from a technology background myself, I saw a lot of opportunities to improve it. So one of the first things I did after graduating from college was to start an organization called Empower with some of my friends to bring the power of technology, especially mobile technology back at that time, this is around 2008, and data to the world of development, and in particular, public health. So the goal was to essentially improve the efficiency and impact of global health programs by using the power of technology. One of the early examples of things that we did was, for example, we worked with BRAC, which is one of the largest global development organizations, an NGO, and we worked with their urban health program and supported them in creating digital data collection at the grassroots by community health workers and using that data to triage pregnant women into different risk categories and then target resources accordingly. So targeting resource allocation, improving the efficiency of the monitoring and reporting processes, those were the kinds of things that we were doing. And some of the key accomplishments over the past 15 years has been, for example, we currently work with about 80,000 health workers in Bangladesh, serving a population of over 100 million people. We were part of the global consortium that developed Open SRP as a global digital public good that is endorsed by the WHO. Some of our interventions have proven efficacy. For example, some work that we did with Johns Hopkins Bloomberg School of Public Health has shown that we can increase ANC utilization by 3x and immunization coverage by almost 2 times. And we've also contributed over the years to national digital health strategies. And more recently, we actually built by ourselves, in the absence of an accident first responder system on the highways of Bangladesh, which is a major killer road accidents in Bangladesh. We created a volunteer-based early responder system, which has recently been taken up by the government to scale up nationwide. So those have been some of the kinds of work that we have done over the years. But in the 7 years that I was very actively involved on a day-to-day with Empower, there were also some frustrations that were creeping up in my own experience. So of course, although we were consultants and technology partners to the development sector, the constraints and the rigidities of the development sector very much influenced us. So for example, the top-down thinking and donor-driven thinking largely in the development space was really challenging to work with sometimes. There were rigidities in the financing processes that meant that a project that's clearly not working on the ground had to be continued for 5 years. And then a report had to be summarily submitted. Sometimes projects that had really good efficacy on the ground and it was really showing impact, but we could not scale it up because donor priorities were shifting, right? And there was also the politics and the corruption of it all. So there was a lot of layers to these challenges that were creeping up. And I think one thing that personally also affected me a lot, being very impact driven, was that I could not, as an external consultant to the development sector, I could not see the impact of my work firsthand, because ultimately it depended, the fidelity of the interventions on the ground depended on the partner and not to ourselves, right? So all of these frustrations were kind of creeping up for me. And at the same time, I was noticing that the private sector, which, and I'm going to talk about a very particular example, but the private sector plays a much bigger role in global health than we give them credit for, right? So in Bangladesh, for example, if you look at the informal private sector, which is essentially drug shops just like this, we treat them in policy just as dispensers, but they're much more than dispensers of medicines. They actually provide counseling services, they provide initial treatment and triage, they refer patients to the right place, often to the wrong place as well. They overprescribe medicines, but that means they actually prescribe medicines. So there's a lot of additional functions in addition to a dispenser that these informal drug shops play. And we often don't give them credit for that or even consider that as a valuable role within the ecosystem. So just some numbers to point out how big they are. There's about 200,000 of them in Bangladesh. They are on average less than 15 minutes away from a household. So they're actually the most accessible form of primary healthcare provider that's available in Bangladesh. And they're actually the dominant national player. So if you look at the numbers, about 67% of first point of care visits actually happens at a drug shop. So that's to tell you how big of an ecosystem that is. But in the 7 years that I spent in boardrooms of NGOs and the government, I never heard about the need for a policy to govern them and to regulate them effectively, right? So that actually led me, the frustrations with the mainstream development sector, but also the opportunities in this space drove me to start my second organization, which is called GEON. And what we wanted to do was to aggregate this really fragmented ecosystem of informal providers and drug shops, and then turn them with the power of technology, with training, with accreditation processes to more effective primary healthcare delivery channels. So that was the goal. And we believe that if we could digitize that ecosystem, in addition to aggregating them, we could also connect them to the more recent advances of technology. So for example, back then, this was the early days of IBM Watson and Babylon. So there was a lot of excitement about AI being able to revolutionize medicine. So we were thinking that maybe if we could start with telemedicine or some form of a digital platform, we would eventually be able to layer on these AI-based assisted diagnostics and triage to be able to empower them and to build their capacity further. So that was the model that we started with. And over the last 8 years, we've worked with various different models. I won't go into the details right now. Happy to chat with you in offline if anybody's interested. But we worked with telemedicine models. We worked with e-learning based models. We worked with an e-commerce model that actually connected them with high quality drug suppliers. And through all of these experiences, we were gradually iterating towards a model that would be able to sustain itself commercially, but also be able to have impact. But then it was around that time that COVID struck, and we found ourselves in a situation where, I'll shorten the presentation, but essentially we were forced to choose between our commercial trajectory and to be able to respond to COVID on the front lines, and that's what we chose. And that, ironically, that actually led us to get to scale. So we were able to do a nationwide drive to train about 25,000 of these informal providers on COVID response and community-based management. So I want to just leave you with one thought, which is, I think Monica mentioned this briefly as well, that the private sector is actually a highly heterogeneous, highly diverse group. And while there are social enterprises like Empower and Geon, which are very impact-oriented and trying to do good things in the space as social enterprises, there's also these informal private sector, the drug shops. There's the large hospitals and corporations that have very strong profit motives. There's, of course, unscrupulous companies that would bribe their way to get a government contract. So all of these are part of the private sector, and to want to lump all of them together and have one set of strategies to steward them effectively is a bit like trying to herd dogs, cats, and mice together into the same pen just because they're mammals. So I think it's really important to consider that heterogeneity and to be able to devise strategies that target them effectively. Thank you. This is from Dali, by the way. So
great. Thanks, Rubaiyat. I'd like to invite Jim to talk a little bit about his engagement with the private sector, and we'll round out this first with Christian after that.
Thank you, Priya. It's a delight to be with you. We have a worksheet. We have a worksheet that's out there. I want to just call your attention to it. I hope you'll be able to scribble some notes on this. We want to capture these and summarize them at the end of the session and post it, make it available, continue the conversation. I'm an old curmudgeon on this panel. I think there's huge opportunity that's being missed. I've worked with WHO and World Bank and USAID and other places in a number of different countries. And I've made mistakes all over the globe. And I hope that with the mix of people that we have in the audience, that you'll avoid some of the stupid mistakes that I've made over the last few years. And the area that I'm going to try and add to the conversation here is, I love the idea of dogs, cats, and mice. That is certainly a diverse part of the private sector, so one size doesn't fit all. But everywhere I turn, there's frustrations about having a sensible conversation between the public sector, the private sector, the faith-based groups, the NGOs as well. And so the only way that I think that we need to add to that is an acknowledgement that we need to redirect the use of funds and also redirect the ability of knowledge and leadership to happen. And the particular area that I'm going to share to stimulate, I hope, some conversation is the whole concept of mobilizing local people into governing arrangements at the micro level. So on this panel, we have represented macro, meso, and micro initiatives to engage more healthy and more effectively the work and the efforts of private sector with the public sector. At the macro level, we have the pontifications of WHO, World Bank, IFC, academics that are here in universities, But we need that. That's a policy framework. It tries to level the playing field. It tries to mitigate against corruption, maximize the opportunity to unleash and empower and enable good initiatives to happen. Where I think the action over the last 10 years has been very much focused, at least at the policy level and at the academic level, and I'm not an academic, although I do get invited into certain faculty roles. I'm on the faculty of Strathmore in Kenya, and I'll talk about that in just a second. So at the meso level, we talk about institutional engagements. And my concern with my friends from World Health is they talk about the commercial development determinants of health, which we do absolutely need to focus on that. But we have to have a good balance between unleashing the potential of commercial enterprises to have a positive impact and not spend all our time hitting them over the head for the stupid things they do, like in tobacco and alcohol and improper food kinds of things. So I'm looking for, on this little form on the left side, you'll see initiatives that could be done to unleash the potential of non-state actors, faith-based, commercial, private, nonprofits, and the like. How can they play a more effective role? I'd like you to each scribble one or two of the things that you know or suspect are going to be working. On the right side of that worksheet is the area of social determinants. I'm, for today's discussion, segregating the commercial determinants, even though that is, as our friend Monica talked about, is absolutely correct, contributes into the social determinants because it deals with jobs and economics. I'd like you to be talking about some specific actions there. And where my remarks in the last 3 or 4 minutes I'm going to take you is filling in the boxes below governance. So I believe that we have, yes, the macro is the policy, the meso is some of the larger institutions unleashing medtech, unleashing artificial intelligence, technology, hospital diagnostic. The IFC, the private banking part of the World Bank, pushes a lot of money out there and really good projects, but very little goes to the micro enterprise. So now in my last remarks, I want to leave with you some initiatives that I hope academics and the public and private sector can pay more attention to. And that is to unleash and to support and to celebrate and to really encourage micro enterprise activities. We've talked about it. We all, some of the older ones here, know about the Grameen Bank initiatives to fund micro enterprise. I've worked with some women cooperatives where they, in rural areas of Kenya, would raise chickens, and in order to both have income, but also food and a little bit to support their community health workers. Of also the drug shops that we heard talked about, they're very powerful. And they're one of the 3 big messages I want to leave you with. There's not a good database in WHO and with the World Bank and with IFC and even with some of the academic universities that are encouraging this dialogue to happen. We don't have a good directory of the myriad of micro enterprises that exist. We don't learn about those. We don't learn what worked and what didn't. So that's one task that I think will help encourage and enable and empower the engagement, Priya and Jerry, with the private sector initiatives. The other element about the micro enterprises in Indonesia, 80 to 90% of employment is through those micro enterprises, and health policy and economic policy rarely gets down to support the micro enterprise activity. I lived in Moscow for a couple of years back when we were friendly there, and we had an award program. So I want to also plant the seed about, if we don't have enough money to fuel and support all the micro enterprises that will contribute to healthy behavior and healthy lifestyles and economic and housing and all the other social determinants, we could at least fund from our friends at IFC or World Bank or WHO a pot of money that gives an award or a recognition for communities or micro enterprises that are doing good things, and then celebrate that and across the globe. For 12 years, I've been a chair of a committee in the United States that uses $100,000 cash award for the community that demonstrates they're harnessing and leveraging social determinants of health, mobilizing the public and private sector, the faith communities to lift up the health of that community and celebrate that. So that's another takeaway that I want to plant is if we can't fund everything, my grandmother used to say, if you can't do everything, that doesn't mean you should do nothing. So I want us to make sure we're coming up with some ideas to document the microenterprises, to celebrate the microenterprises. And the last comment, and this is the most important, I think, is we did a study for USAID in the 54 countries of Africa, because there's a lot of frustration that donor money was leaking and local investments into health were leaking, driving toward 15% of trying to encourage better health in the public and private sector, but most of it was on the public sector, very little attention to enable the private sector. And we found out by looking at all the potential boards of community people invited to serve, to govern better engagement of public and private. There were 177,000 governing bodies in the continent of Africa. And there's 1,100,000 people that were invited to serve on those bodies to encourage public and private dialogue, to encourage microenterprise, to encourage health centers and hospitals, but very little support for those. So I'm working now in Kenya. Kenya's devolved, as some of you know, into 47 counties. We're launching a governance training program with the business school in Nairobi and with the county governments to lift up the training for those people. We need money to flow to microenterprises, and we need knowledge and governance capabilities to flow. And so we don't have time to go into all of those, but one area that I would encourage us to talk about to insert the lever to change is better governance, better boards, better people, and supported local grassroots people into the microenterprise, not just the bigger commercial activities. So.
Great. Thanks, Jim. And last but not the least, a set of comments from Christian, and we will open to questions from Jerry and then the audience.
Well, thank you very much. I think that's fine. Thank you for the invitation. It's a pleasure to be here. And I think I was invited also because Priya also mentioned it, my two hats, like my previous life in government and now in the international organizations world. I was at the OECD, now at the World Bank. So the first point I wanted to mention and to discuss with you is it comes from my time in government, actually, and talking about commercial determinants of health, something that I learned with many ups and downs and many anecdotes. I was mentioning this before, but is that commercial determinants and the private sector, public sector, and so on are very closely intertwined with political determinants of health. Is something that is when you are in government is unavoidable. It's almost a daily thing that you are managing politics and the issues related in this case, amongst others, of course, related to commercial determinants of health. In my case, in my experience, for example, I was involved in developing a policy in Chile related with front of package labeling of food. And now Chile from many years now has this black sign saying high in calories, high in salt, in sodium, and so on, different measures. And then you can imagine how difficult this was in terms of the food industry and many other actors. And every time this was also linked to politics, to the political determinants of health. Also, I was involved in a national policy to cover high-cost treatments. So this is obviously related in most of cases, not all, but most of cases with pharmaceuticals, in some cases devices as well. And again, all this was related not only with the technical things, with the commercial, the private stuff, but with politics and how you align different players, including Congress, of course, very important, including civil society people to back what you were supporting, and finally to hopefully, this is not always possible, but to align as much as possible and to generate the consensus amongst in the key areas of these policies. These are just examples there. And one thing that I think it was very important, and also now learning from other countries, is that these rules of engagement, as this session is trying to address, is very related to institutions and how institutions are shaping and steering all these processes, of commercial, political, and so on, and amongst all these actors. I must say that in Chile, institutions are relatively good, so it was relatively it facilitated to have all these discussions, to put all the interest on the table with relative transparency. Of course there are problems, but also when you think of these institutions, this can also, for example, Rubaiyat mentioned that corruption can facilitate corruption, or can make it difficult to have corruption in the relationship between all actors, private, public, and so on. So I would say that that's a key issue, how you develop strong institutions in countries that generate this playing field, the rules of engagement that are clear, that are transparent, that everyone knows, and in the end generate a good scenario for all this to happen. The second point, and I want to move to everyone, of course, we have been talking a lot about COVID, but we did a study in the World Bank in Latin America on how this played out. And the public-private interaction was very, very clear in all the things, all the interviews, in the data we collected, and all that. And I wanted to mention two things. So first, Latin America and the Caribbean has one common feature: fragmentation. And this is common in other regions as well, right? But fragmentation of health systems is something that is very common. And what happens is that, as in other regions as well, and the richest part of the population normally uses the private sector, insurance and provision, and the middle classes and the poorest part of the population goes to the public sector, right? Obviously, they cross in many cases, but in general, this is what happens. But during COVID, this was kind of shaken a bit, in the sense that the systems had to work as a single system, as a one health system. And in many countries, the Ministry of Health took the steering role, the governance role there to coordinate all these public and private actors. And in many cases, for example, Mexico, Colombia, Chile, patients it didn't matter what was their insurance, if they were receiving care in the public or private. If they had COVID, they will go to the system that was single, and the government was saying patients will go here, there, public, private, it didn't matter, right? And I think this is a huge lesson learned, because this worked much better for patients and also worked better for providers, both private and public, right? Because in the end, all the capacity of the private, because the demand was so huge, of course, but it was coordinated, and the prices that were paid and all were agreed in a situation of crisis. This was, of course, not business as usual or regular times, but I think much lessons learned can be taken from that. But the second point, and this is my final, in one of the things we learned, is that going back to institutions in this case, is that in some countries the public sector is so weak that there are basic problems, and just let me give you an example. In one country, and this again happened in others, but the distribution of vaccines the public sector was not able to do it. They had to partner with the private sector. But in this case, that I always remember it was the largest beer company in the country that had the capacity to distribute, because they distributed beer across the country, no, and in cold beer. So they had the trucks, they had the places to keep all these. So they had to use the largest beer company. And of course, in times of crisis, you say, that's great. I mean, it's good, because in that way, they managed to deliver COVID vaccines to the population. And they did a good job in this country. They're very good. But at the same time, going back to institution, this is a sign that you need to have some basic stuff, that you cannot rely, no, for these type of things on the willingness, in this case, of the private sector. So this is something that it needs to reach a balance, and again, the combination of public-private probably is the best solution. But you need to have this type of public goods strong enough in a basic level that can be done with a public-private collaboration. But in many cases, it has to be public. That's something that you really need to consider. No, yeah. So many things to say, but just that's a starting point.
Thanks, Christian. Great points. Over to you, Jerry.
Okay, well, I've been given the task of asking questions. First, to say, please start thinking of the questions you want to ask. But I guess I reflect on 4 really good presentations, I must say, but 2 key themes came out. And so I wanted to ask questions on and two people each on one theme. So one of the themes started with the example of tobacco, where we know that the commercial determinants are all weighted in one direction. But I think what Monica said is there are many other activities, products where this benefit. I mean, we can't have cities provisioned without food processing, but we need healthy food processing. We can't have cities without commercial cooking of food and making it available, but we need it to be healthy. So there's a balance to be brought, and a balance that crosses from the way we think about it in health, different sectors. And again, we heard from Christian about the importance of institutions. And so I guess I would add, but again, institutions that are either with local government and national ministries, or institutions in health and other sectors. So I guess for both of you, it is now, what examples can you bring of where institutions functioned effectively to balance these harms and benefits? And what are the key messages you would bring to, I guess, a more general discussion about how do we have effective engagement with the private sector that protects the public good? And it would be good to hear both of your reflections, but the others, I was surprised. Both are on what I think was beautifully called microenterprise, although 15 years ago they were called community health workers. And I guess we all know that many community health workers in the end, some of them are now drug shops, but all of them have had to find ways of earning a living as well as getting a government salary. So our public health language of community health workers is awfully close to microenterprises. And so I wanted to ask questions about that. I mean, Drew Bayat, and it's because we had a discussion. I mean, we can all imagine with 180 or 200,000 drug shops, and the technology would be so easy to take people's blood pressure, to test people's blood sugar, to monitor health, for government to have a very easy win of providing access to basic monitoring and management of hypertension and diabetes. What do you see as what's the challenge in taking it to scale, and what does government need to do to be able to get the benefits of this, but prevent the harms that you've already mentioned by essentially commercial drug shops who could exploit people? So how do you see that kind of engagement work? And I guess it's the same thing with Jim. I mean, you said something tantalizing, so I guess I would go further. I mean, are you saying in a way we need to broaden our thinking about community health workers to a broader understanding of what we're calling microenterprises? And where do you see the Ministry of Health functioning, or other government ministries? And again, how do we encourage beneficial local activities while protecting people against possible harms? So again, it's an institution issue, but it's much more about local governance. So I don't know, why don't we just, well, why don't we go, because we have an order here. Why don't you start, Rubaiyat, and then Jim, so that we have that one, and then Monica. Christian.
Thanks, Jerry. So I think as a technologist, when I started in this space, I was very naive in thinking that technology would solve a lot of things. But then I realized that the technology can only operate within a system that's functional, right? So I'll give you a few examples of why it might be challenging to actually roll out NCD care through drug shops. So first point to note is that they're already doing it, right? So we did a survey around Dhaka city in the peri-urban areas, and about 80% of pharmacies were already carrying a glucometer, a BP machine, and they were doing routine monitoring for their patients. 8 to 10 patients were showing up every day to get their blood sugar checked and so on. The problem is that they have absolutely no training in how to deliver protocol-based care for NCDs. And NCDs are particularly well suited to protocol-based care because you don't need any advanced diagnostics. Just with BP machines and glucometers, you can actually do a fair bit. So the example that I want to go back to is telemedicine when we rolled it out with drug shops. And the problem we faced in scaling it up was that having them refer a patient to a telemedicine doctor, a physician who's sitting maybe 200 miles away, was challenging because these providers actually are known in the community as the local doctors. They're actually called village doctors. That's the formal terminology for them. So if they're referring their patients to another doctor, what are they? So it kind of causes an identity crisis, right? And it shows them to be weaker than they want to be represented in front of the community. So there's that reputational aspect to this, in addition to the monetary, like even though we were compensating them financially quite a bit, that was not enough to to compensate for the reputational loss that they would face as a result of this. The other thing that what that point highlights is that in addition to income and commercial incentives, there's also the incentives that's associated with reputation and the way they view themselves and the community view them, right? There's also a lot of perverse incentives at play. So the reason they overprescribe medicines is not just because they want to make a quick buck. It's because the pharmaceutical companies are pushing those advanced drugs down their throats. It's also because patients who are poor people looking to get back to work the next day, they're also actually seeking the most advanced drug that will get them back on their feet as quickly as possible. So when your client, your customer is asking for that drug and your supplier is also pushing you to sell it, what would you do as a commercial player, right? So these are the kind of complex systems within which we're operating. And so it's really important. I do believe, Jerry, that there's a real potential to use drug shops to scale up NCD care in emerging markets because they're so close to the community. There's such good knowledge they have of the community and its people. So they could very easily identify. During COVID, one of the things they did in Bangladesh was to create a risk register of all the people in their community who were at risk of COVID or had the risk factors, right? So those kinds of things can very easily be done using these close to community providers. But the challenges will be in designing the right incentive structure for them to be able to follow the protocols, to not have these perverse incentives to overprescribe or to prescribe the wrong medicines. And finally, I'll also mention that there's also a political challenge because it's really embarrassing for a government to acknowledge that 70% of your care is delivered by the informal sector because you're spending billions of dollars in building thousands of community clinics and then people are still going to the informal sector. Why is that happening? So just acknowledging that and working with informal sector would take a huge ego hit for the government. And that's not something that I think they're ready for right now.
I hope Jim may have a couple comments on that as well.
You asked about the Ministry of Health. I would say it's beyond the Ministry of Health. We need to look at engaging the Ministry of Health with the Ministry of Finance and with the Ministry of Economic Development. That would be one comment. And then the public sector through the Ministry of Health has both incentives. They rarely offer incentives for microenterprise to flourish or to scale up. There is certainly a role for the ministry to look at basic capabilities of healthcare workers, basic capabilities. This is the regulatory role, as long as it's not a very large sledgehammer that's used to stifle the opportunity for innovation. But government, the public sector, must play both roles, the regulatory role to get rid of the bad actors, but what they're weakest at is providing incentives. They don't offer recognition and awards. The reputational risk is real. And one way you can do that is to celebrate people that are doing the good things, not to be Pollyanna about it, not to ignore the regulatory constraints, but to really be much more creative on how we celebrate and recognize and provide training opportunities and gift cards. We found, even in the United States, gift cards for these community leaders working in federally qualified community health centers and the like, for dinner for two can be a nice recognition and reward for people doing good things and innovating. So I think we're going to have to look at the public sector role being both the regulatory and the incentivizing. And in between is enabling capacity development.
Well, thanks. You both of you have brought up a lot of food for thought, and I hope people will raise some difficult questions about what they're proposing. But why don't you go, Monica?
Thank you very much, Jerry. And it's very difficult not to comment on what I've just heard, but to stick to your question. So if I understood your question correctly, you're referring to what is so increasingly be called an issue of alignment. So where we have sort of disalignment with health objectives, and most clearly the tobacco industry example, but also arms, and seeing that as a scale of alignment across different sectors. And it's a very compelling and interesting concept. It's very challenging in practice, and I sort of noted down a couple of challenges. And I think the first one that springs to mind is the complexity of corporate ownership that we see at the moment. So, for example, there was a lot of visibility around the entry of the tobacco industry into the pharmaceutical space. In some cases, when we're considering large multinationals, their portfolio of products is very diverse. And I didn't mention this in my presentation, but one of the drivers of this as a topic of sort of global discussion and concern is, of course, the link to the global burden of disease. And in the Lancet series that I mentioned, they propose that almost a third of all preventable global mortality is linked to just 4 industries, and that is tobacco, unhealthy food, alcohol, and fossil fuel. Now, that's a huge, huge burden that we're talking about, and the complexity of the relationship amongst the commercial actors involved is very real. But the second challenge is that even within that sort of industry block, we're talking about the level of diversity that was mentioned and the heterogeneity. So, for example, in the tobacco space, if we stick there, small farmers, small retailers that are indeed micro companies. That doesn't mean that that we want to be looking at incentives from their side from a health perspective, but rather we want to be looking at supporting the ecosystem. And I fully agree with you, Jim, in order to be able to move community enterprises into spaces which are health promoting, and really sort of linking us back to some of the origins of what we're talking about here and in health promotion. And then so my final point around that is that this is also an issue of the commercial actor and corporate governance per se, because we cannot forget that often legally commercial actors are bound by the profit motive. It is their legal obligation. It is what they're there to do. It's what they do best, in fact. And engaging with the private sector, we need to be mindful that a lot of the time the private sector is engaged exactly where it wants to be. So looking at the private sector, parts of the private sector, the ecosystem, where there is opportunity to lever some of the co-benefits, particularly on the community level. How does the informal part of our sector fit into those conversations? How do the micro elements fit into that? That's a very, very important direction of inquiry. And I have some thoughts about that, but I'm coming to the end of my time for the questions. So Jerry, I'll pass back to you. Thank you.
Christian.
Thank you. Yes. So institutions. I think that was the main the main word, the key concept. I take the macro, meso, and micro, because at the macro level, and this is moving to what is happening now a bit. Probably the biggest issue that directly impacts health as well, but much more than that, of course, is climate change, right? And the World Bank, this is a key priority in terms of what to do, where to invest, where to provide technical assistance, and so on. And here there are, well, of course, the official institutions, but others like the Pandemic Fund. You probably have heard of that one, relatively new, that is trying to again set some rules or where international funding from different agencies, and this is in partnership. Of course, WHO is the technical lead for this work, and is generating these institutions, which are kind of more. Some of them are more formal, are written, and they have the rules, etc. But they also generate like informal, like a culture, a way of thinking, a way of behaving that comes along with generating these formal institutions. And I think that's very, very important. And this then translates to what happens in countries. When we go, for example, from the World Bank to work with countries, with governments, and IFC, which is the private side of the World Bank, all these ideas, and kind of rules that are set at the macro, international, global level, comes with us when we work with countries, and with all the different players there. So when the funding is coming, it's also generating some type of new institutions, or shaping in some way, obviously with governments and national actors, the institutions that will be playing in that phase. And I'm thinking, going back again to the second big area that the World Bank also has as a key priority, which is pandemics. How to prevent, prepare, and be prepared to respond for the future pandemics. But of course, the prevention is the most important part, and surveillance. And I will just make a double click on surveillance. Surveillance is probably one of the key, most important areas to avoid, to prevent as much as possible the next pandemic. And it will be for epidemics also in countries. Early detection, that's probably the key thing on this area, how to early detect in terms of surveillance. For this, the partnership with the private sector is key. Most of this laboratory surveillance, genomics, innovation, and so on happens in the private sector, and then in partnership with public institutions. And again, all the rules and all the things that are coming from what we do, and in the region in Latin America, for example, with PAHO, with the Pan American Health Organization, then translates to what happens in countries, and this generates transparency, generates engagement in a more collaborative way. And I think that's crucial. Institutions in this case, and in this type of big issues, needs to lean more towards collaboration more than competition. And I know that for the private sector, usually competition is the key word, and that's perfectly fine. But for this type of big issues, we probably need to lean more towards collaboration, and institution needs to generate the scenario to have that more happening in practice, right? So I will stop there. That point.
Great points. Jerry, I was wondering, maybe now, we still have a little bit of time left. Would you like to open it to some questions, and then we can come back? So I think we have one at the back.
And please introduce yourself.
Yeah, do introduce yourself and come up in front. I mean, no formality here. I think I'll just... Okay, so there is a mic. All right.
Okay. First of all, my name is Medha Chaturvedi. I am at the Heidelberg University in Germany. And first of all, I would like to say that this has been a rather fascinating presentation of commercial determinants of health. This is something I have studied in the past, and I have had several questions about this. Don't worry, I won't bring up all of them here. But I do want to give an example here and based on that example, ask a question. So one of the primary topics of my research had been looking at the corporate social responsibility, mining, and production of ill health. And as a part of that, I do have some question related to that, is that we were talking about incentivizing for example, good behavior or not behavior, but good actions with regard to controlling the ill health that is produced as a result of profit motive. But incentivizing that is a good idea. But what about disincentivizing the production of that good health, of that bad health in itself? And how can that be done in general? Because in a lot of cases, especially with regard to mining, which I am aware of, is that the governments are very much involved with the corporate entities in creating this production of bad health. So how can this be sort of let's say resolved in order to make this a more streamlined process, so that the production of ill health is not there at all, or it is disincentivized to a point that it is no longer the scale of the problem is no longer as it is right now. Thank you.
So disincentivization of bad health and using mining as so whom would you like to
I would say in the mining area, you have regulations to promote public employee safety and the use of the runoffs and all of that. That's one role. The other is to engage in a partnership with media to embarrass or to chastise them for bad actions or bad results. And then the third is to offer recognition and reward for those that are doing good things. There's no single answer, but you're going to have to be able to use carrot and stick kinds of analogies in that particular area, not just in mining, but some of the other commercial negative impact corporations.
It's a huge question. I was trying to think how to tackle it, but I think in this case is interest clashing, the profit and on the other side the protection of workers or environment, that comes along. And Chile is a huge mining country, so that's why I'm also a bit aware. It's not my area, not my sector, but in general terms, I think the thing of regulation and incentive coming from the government towards the relationship with the private sector, I think it's a good way to put it. No, you need a strong public sector for both, and to make to incentivize and to generate the space for the private development of mining. That's absolutely, because they generate also public goods in the end, with that are used for other things and the economy and so on. But then you need a strong public sector also to regulate and to generate the rules to protect all these other things. And again, I think this is linked to politics, as I was saying. It's also related with the political determinants. There are views of the world, ideas that shape what you do, or if you lean more to one side or to the other. If we talk about regulation or incentive of the private sector, but in the end, yeah, you need to have a balance. But for either or both, you need a strong and I'm sorry if I think a lot of weak public sector, because I see a lot of that when we work with countries, and I think it's even better for private sector if you have a good public sector at the same time, and to have both. I'm not saying that it has to be both, for absolutely, but it's even better for private sector if you have a good public sector.
I think Monica had a comment, and then we can move on to the next question.
Yeah, thank you very much for the question. And I think you've so using the extractive industry example, I think you've hit the nail on some of the biggest challenges that we face in the area. Oh, and a couple of things that I didn't mention up until now, but are very important. So one of the challenges that we see in commercial determinants is that too often the externalities and costs are borne by the public sector, whereas the profit is held by the private sector. So in this example, I think this is very much the case. And in this case, it wasn't clear to me if perhaps you meant all of it, whether we were talking about harms for workers or harms for community or broader harms in terms of the environment and climate. So in any of those cases, the externalities are borne by the public sector and the broader population, whereas the profit margin stays within the private sector hands. And one of the work that we've started the commercial determinants work 2 years ago. So this is still a very new area of inquiry for WHO. And we're working towards synthesizing the evidence in order to provide the overview and the recommendations for action next year. So, and as part of that process, there are 5 main drivers that are emerging as a way to address what you're presenting, but across different sectors. So this is still very much a work in progress. And so please do not take this as infinitive, but I think they're illustrative for your point. So the first one, then, to echo the points of Christian, the public sector space, so the regulatory capacity, but also the enforcement capacity of the public sector in order to be able to direct the accountability of the activities that we're talking about. The second part is corporate governance, and that's very important. So when we have the accountability within the company towards their own shareholders, towards their boards, so looking at the corporate governance processes and the ESG criteria, so how we can strengthen health within that and more broadly is the second dimension. The third dimension, as Jim mentioned, is social demand and the public pressure in terms of better corporate behavior within, which is, again, not to be underestimated. It's not a silver bullet, but it's certainly important for the political conditions for action there. The fourth, and it hasn't come up, but it's very important, and that is the knowledge environment. So how the science that we are presented with is influenced by commercial interests, funded by commercial interests, and not funded in the areas that sometimes we might need it to be. So this is an area which is very important for us to think about. And fifth dimension is the international instruments and mechanisms that we have at our disposal, whether they're hard instruments, legal instruments, but also the financing instruments and others. So this is a very sort of top level set of drivers, but as food for thought for our discussions, I'd like to put them forward.
Thanks, Monica. Let's open out to a couple of other questions. I think, yeah, there are a few down the line, and then we'll.
Hello, my name is Liza Dunn. I am the medical affairs lead for the crop science division of Bayer. I'm here because I think this is a really important discussion. Companies have been essentially a lot of times tobacconized, and I came from academia and went into industry. And I realized that I had a lot of misperceptions about how companies operate. I think companies have the ability to do big international projects and really are the face of implementation science. So my question for you is, how do we, and we've seen this with COVID, we've seen how wonderful the private public partnership worked. How can we start to rebuild trust with the public and academic center so we can achieve these really important projects and goals?
Great question. Maybe we can take a couple of questions, and then, people can pick what they want to answer. So this one is around rebuilding trust, and we can see who wants to answer that. Jerry, please.
Thank you. Great discussion. Of course, I'm going to start saying that I think the importance that you put on the heterogeneity is very, very important. And you see that also in the presentations. We're talking about a lot of different things. So I want to talk here about the harmful part of actions of industry. That goes beyond the NCDs. I think mining was already mentioned, but also, we have a long trajectory in environmental and occupational health, dumping of pesticides, all the practices that are still going on, which have to do with weak governance, with conflicts of interest. We all know what happens at the negotiations in many countries because they need to accept they don't have the muscle to stand up to industry that they already know is going to be harmful for their workers, but also for their environment, etc. So what do we need now? Some kind of a global watchdog or a global what's the global role we need to play that will support countries in putting that muscle and to make sure that this kind of dumping and practices don't continue? And of course, I'm looking particularly at WHO and PAHO and World Bank. I am Gerry Eikemans. I'm the director of the Social and Environmental Determinants and Equity area of the Pan American Health Organization since 1 week. So please don't pin me down on this. But and environmental health and commercial determinants are part of that, obviously. So really that global role and that global watchdog role with communities, with civil society, with intersectoral action, etc. Thank you.
So do we need a global watchdog which deals with intersectorality and equity? We can take one more question, then we'll have a round of answers, and then may I come back to you, sir? And I think there was one more over there. Yeah. Yes, go ahead.
Oh.
You have a question? Okay.
Thank you. Great panel. Very important. My name is Steve Hargard. I'm an emergency physician from the Medical College of Wisconsin and founding dean of global health. I bring a question particularly to Monica and Christian about guns. When can we get guns as commercial determinants of health bubbling up on the WHO agenda? It has been recently described in some of the public health literature. Would welcome your comments, Monica. And turning to Christian, half of all gun violent deaths in the world occur in 6 countries in the Americas: United States, Brazil, Guatemala, Colombia, and Venezuela. How can we work together to address that commercial determinant of health that is disrupting communities, forced migrations, and causing hundreds of thousands of tragedies? Thank you.
Great question. Let's pause here and work backwards. So that's a great question. So Monica and Christian, would you like to take that, then work backwards to, do we need a watchdog? And then one step back to building trust. And so why don't we kind of, start from
Priya, would you like us to address all 3 questions in our intervention?
Yeah. You can start, and then we can open it to Jim and Rubaiyat as well.
Thank you very much. So it's very easy to start with the last question, because from a WHO perspective, the weapons and guns and the arms industry is part of the conceptualization of the commercial determinants of health. It's an industry that we don't work with at all, and it's very firmly there as part of that. So that's very easy to say for me. Now, the challenge for us is then to integrate that as part of our thinking and our frameworks and recommendations for action. So that's next. Moving on to Jerry's very important question. And again, so I'm preempting a little bit some of the discussions because we're still in the scoping phase, but it's certainly clear that what's emerging is that there is a need for a greater accountability function that also exists at the global level. So what that looks like, I think, is a question for others, perhaps, but that's certainly a need that's emerging. And one of and I'm going to sort of use that, if I may, to make 2 points. So one, and Christian mentioned the issue of surveillance, and certainly, we all of us in public health know that good policy, good action starts with surveillance, and we're not currently surveilling commercial determinants of health. So it's not integrated in public health surveillance systems. There've been calls for this, whether this is at local level, at national level, but it's very important that we start to look at some of these issues in order to start to be better prepared in terms of how we move and address it. And the second part of that, and Jerry, you mentioned intersectoral action, and I think this is very important. This is not new. I mean, you certainly know this better than most of us, I think, as well. Intersectoral action is a fundamental principle of health promotion and social determinants of health. It is a core part of the strategy for implementation, and it has been for a long time. Doesn't mean we do it very well or very consistently. But I think that there are 2 parts of that we need to start to look at and need to be very mindful when we are talking about this in the context of commercial determinants. The first one is that intersectoral or multi-sectoral action is not the same as multi-stakeholder action. So multi-stakeholderism and multi-sectoralism are not the same approaches. They are complementary, but they do very different roles. Now, this is, I mean, I'm speaking academically, so for those of you, forgive me for this sort of point of concept, but it's a very important one, because our issues for the rules of engagement for implementation stem from what it is that we are taking as our approach, whether this is multi-stakeholder or multi-sectoral. They're not the same. And the second point within that, I think I've forgotten, so I'm going to leave it for now. If it comes back to me, I'll come back. Thank you.
Great, Christian, and then we can have one more round of questions.
I didn't answer on trust. Can I just answer? So I think this is an incredibly important question. I'm trying to look at the lady from there who asked it, and it reflects a broader discussion here that it's not only, we've seen this in the trust survey, the Edelman Trust Survey, which is such a sort of fantastic point for this, for example, demonstrated that we're seeing a loss of trust in different institutions, not only in the private sector, but also in parts of the public sector. So trust as part of our governance conversation and is a very important part of that. I don't have a solution. I don't have a proposal at this point, but I think it's it's very good for us to note as part of this conversation and look at how we can explore that further.
Okay, great question. So huge, again, topics there. I will start also the same order. Guns. I totally agree. It is a commercial determinant of health, and probably more than that. But in terms of the Americas, I don't know where our colleague, sorry, over there, thank you. But the situation with guns in the Americas, it varies a lot between countries. But I must say that the US is very different from Latin America. What is driving the issues, no? In Latin America, it's more related with criminality, with the drugs, like illegal drugs, the narcos, as we call it, and so that's the main driver of this, and it's growing, unfortunately. So it's different from the US in the sense that in the US it has to do a lot with availability, with access for the general population. It's also in Latin America is more concentrated in poorest, more vulnerable parts of the population where guns are used and are harming people and so on. In the US, access is much larger in general for the population, is more distributed, you could say. But just to say that the issue is guns, but the approach has to be different. Talking about diversity, and it's not one size fits all at all, but it's all connected. But for sure, it will be interesting to see what can be done in that area. Global watchdog. Immediately I think of on the entities that currently are doing that in some way. So the World Trade Organization, and also in the World Bank, the bank is the World Bank Group. There is one of the 5 institutions is related to disputes, to how to solve disputes between public-private or private-private actors and so on at the international level. In some way that generates this, again, rule making or sets precedent for how then countries continue doing things. But there is no, I would say, institution doing that, entity doing that at the moment. You can think of WHO immediately that could take a role, but it goes much farther than just health. So that's why I think maybe in the World Trade Organization could be, but there is also other institutions that work in the areas of policies, of generating proposals for ideas. The OECD, for example, they also work on this type of in areas. They work mostly for developed countries, for high-income countries, and some upper middle. But again, policy decisions can go from there to other countries. So maybe it's not just about having a watchdog that can kind of intervene, but just to foster ideas and ways of developing policies within countries at the same time between different entities. And trust, and I can, for me, I immediately think on COVID. People was not going to institutions, both public and private, because they didn't trust them. And this moves away also from the health sector. People, and I know much more, of course, of Latin America and the Caribbean, people is not trusting institutions in general, in public and private. They don't think they will be solving their problems. In not only in health again, and the issue also is that when you have such a divide between public and private, what happens in practice is that sometimes people trust in one and not in the other, and that's harmful in general. People start, and what happens is that they trust more in the private. That's what I've seen and I've experienced in different countries in LAC, in Latin America, but less in the public, and that's obviously bad for the whole system. No, so again, I go back to the collaboration here. Partnership, collaboration, especially in these rules of engagement, should be central. We need to avoid competing, in this area, in this field.
Thanks, Christian. I think there is room for one more question. We're almost edging towards the end of time. This gentleman has been really waiting for a long time, so I'd like to give him the floor, and then we'll see, depending on. Yes.
Not that long time. Carlos Santos Burgoa, professor of global health policy at the George Washington University. Thank you very much for all the presentations. A couple of issues, all of them related to intention. Maybe we are being naive in how we are addressing these issues. Are we really talking about commercial determinants equal to social determinants, or are we talking about commercial forces that are trying to influence actively policies? So thinking about just a determinant is different to thinking about a force. What's the force behind the arms industry? What is the force behind the food industry? What are they trying to push? So the first question is, shouldn't we consider this on the intentionality that these actors have behind it? And the second part that I completely agree with you, Chris, is the issue of the strength of the state to deal with these forces. Okay, here we are confronting a structural problem that the state has been shrinking and shrinking and shrinking. WHO, the budget of WHO of PAHO is relatively shrinking in comparison to the growth of population and the whole economy. So how we want to develop our institutions, our regulatory institutions, and how we want these institutions to work, not leveling the field, but moving the field in such a way that it protects and promotes health.
Thank you. I guess the question is around commercial forces, and the second is the state shrinking, and what should we do about it? Maybe we could start with Jim, if you'd like to kind of address the question of commercial forces, and Monica, would you like to address the part about the state shrinking? And finally, actually, I'd like to loop in Rubaiyat, because I'd really like to hear his points about building a brokerage of trust, because he comes from the entrepreneurial space. And I think with that, we will pretty much round out the session. So over to you, and any other further questions, perhaps we could do that offline. We're really short for time, but I'll have you in mind. So please go ahead, Jim.
The role of the state is shrinking. The role of the private sector should grow. The role of the private sector should grow, but not unchecked. So that's the regulatory balance between the two. It's a healthy dialogue and debate you just started, but we can't possibly address it. But I'll leave it at that.
Yes, I agree with Jim. the role of the public sector is shrinking, and this is one of the, and you've raised such a fantastic set of questions that I'm having to sit on my hands not to launch into. But your point about commercial forces as part of the conceptualization of commercial determinants is very well taken, and it is there in the modern definitions of commercial determinants, and it links us immediately to the economic determinants and the economic structures and forces that reinforce them. So this is very much part of our thinking. So without sort of going into that, I'm going to leave it there and say it. But I did remember my previous point, and that is around health and all policies, because in sense checking some of this work with the member states, which is of course a very important part of our mandate and how WHO and PAHO work, the message from the ministries of health is very clear that we have existing frameworks linked to the work on health and intersectoral action, including health and all policies, and seeing how we can use these existing frameworks where they're there to learn lessons, for example, from the frameworks in the health system space, but also to include conflicts of interest and commercial determinants as part of our health and all policies approaches, to see how this is where we have other ministries who have the primary relationship with the economic partners, with our commercial actors, and not the Ministry of Health as well. So I wanted to put that onto the agenda before I forget. Thank you.
Monica. And then we'll get Rubaiyat to have the last word, and then Jerry will wrap up. Apologies, we're really out of time, so we are hard pressed.
Thank you, Priya. So I think fundamentally trust is about humility and respect, right? So in our interactions with the government, it often feels like the government can do everything by itself, which is not the case if we look at where most of the healthcare is being delivered. So that humility of inviting the private sector to the table, and not just the big pharma and cowering to their interests, but also smaller enterprises like ours who bring specific skills to the table and can really support the government in furthering some of these goals. I think that's really, really essential. And showing that respect to us as well. I think that's really important. And I think, yeah, and not asking for bribes. I think that would also help. Thank you.
I think I will. Well, first, I mean, that was really an excellent discussion. I guess I wanted to say a couple of things, partly to bring these two strands together, because on the one hand, there's a discussion of large companies, and I thought when it was asked about mining, now the rush to get new minerals for green energy is a very important. We have lots of big forces, clearly, but I want to come back to see if we can bring this discussion, how the different strands fit together. And in a way, it's what Christian said, is on the one hand, there are some areas where there are real just threats to health. On the other hand, he said, how do we get a cooperative approach that can start solving health problems? And I think we have to have both in mind. And I guess my other thought is, in hearing the discussion by Rubaiyat and Jim, is in many countries, if anything, as the state has become less important, the informal sector has become more important. And that's how people are earning a living. And a number of them, we've heard, are earning a living in health-related activities. And they are usually left out of the discussion, which is in a sense what Rubaiyat said. And they're also private, and they're also a response to what's been happening about the loss of formal employment. So I guess we want to have a more general, I think this is about getting a general framework that moves away from is private good or private bad to how does the state engage with this complex environment? When does it have to be focused very much on eliminating bads? And when can it try to build this kind of more cooperative approach, which can include, as Christian said, leading scientists, but it may also include drug sellers who have no other way of earning a living. So I think those are the big questions. And I guess what it led to, I wrote here. I think one of the key questions then is, because what are the roles and responsibilities of different kinds of enterprises? If the informal sector is allowed more respect, what is their responsibility? How is this going to be defined? Because there was a bit of almost despair that that's not possible. Because people have to earn a living, they may be driven entirely by the private sector. I'm not sure that that's always the case, and I think that's what we need to explore. So what are the responsibilities of different kinds of enterprises? Where is it possible? But then again, what is the role of the government to negotiate these kind of partnerships and to protect the public? Because we can talk in glowing terms about the informal sector, but they can do plenty of harm, as well as the formal sector. So how does government act? And you've said in a context of shrinking government, when we're talking about the informal sector, what's the role of public finance? Is it only to fund the public sector employees? Or should this informal sector of micro institutions or whatever have a claim on some of the public finance if they're going to solve health problems? Where is the space for innovation? Jim particularly raised this question. Where can innovation? We're in a period where not only are technologies changing fast, but organizations are changing fast. And digital technology is making it even more possible for the construction of organizations to change. So where's the room for innovation, but protecting against bad innovation? And I think the big questions were raised that I guess I want to come to, and I guess it's what we said, what are the rules of engagement? And in a way, Christian said politics. And I think we've said politics is important, but we haven't gone very far. What does politics, and politics is partly government he talked about, it's political parties, and it's also movements. And where are they in constructing these kind of new partnerships? And I put here, what are the role of citizens? And actually, we haven't discussed it amazingly, given our world, very much other than Monica, the knowledge environment. But how do citizens get access to reliable knowledge so they can be effective in this environment with a lot of informal activities, with a lot of big companies and the state with struggling? How can people be more effective as citizens in making the system more accountable? And the last one I put here is people raise the question, and we have someone from WHO, what are the role of international rules? But we have to be aware we're in a period now of global contestation, and international rules will have to be negotiated. And I guess, luckily, we have people from the World Bank and from WHO who can be part of trying to negotiate these kind of international agreements. But I think we have to recognize the kind of agreements we had 10 years ago don't hold now. We need to have the key players at the table agreeing to the rules. And how do we see national level efforts now to tackle I think we have a broader environment. It's not just about the private sector and health, it's the private sector and health, and it requires a much more creative way of building partnerships for health. And I guess I'm a researcher, and so is Priya. I think we would have to say, my conclusion from the discussion, lots of good ideas, not one sense of a vision of what we're going to have in 5 to 10 years from now. And maybe we also have to be a bit humble and realize there's going to have to be a lot of learning involved, and a lot of trial and error and building experiences. And we need, from our point of view, the research community has to shift from documenting the past, documenting interesting things, to being part of this change process. And that's, I think, where I'd like to end, that this was a great panel. You've created an enormous agenda for problem solving. You haven't created any answers, but I hope we're going to meet again in a few years to see where we've moved this. And thank you very much for some great questions.
Thanks, Jerry.
Thank you.